Thank you for joining us on this lecture from the Cambridge University Science and Policy Exchange on comparing outbreaks, the policy response to COVID-19 and Ebola. My name is Sarah and I'm half of the lectures team here at CUSP, and it's a huge pleasure to welcome Dr. Jane Greatorex tonight to our virtual talk to discuss her experiences of crisis management during pandemics. So a bit of a structure for the evening. After a quick introduction, Jane will present for around half an hour, followed by plenty of time for questions and discussions. If you have questions throughout the talk, feel free to either pop them in the chat or keep them in mind until the end, and we'll invite you to unmute and ask your questions. If you'd like our guest or I to ask the questions on your behalf, please just indicate that by typing "please ask" or something in the chat. So to introduce our speaker, Dr. Jane Greatorex is an academic and clinical scientist here at the University of Cambridge. She specialises in blood-borne viruses, including HIV and Ebola. And in 2015, Jane was a team leader in Sierra Leone during the Ebola outbreak. She remains on the list of scientists who could be called upon should another outbreak occur. Jane also researches the influenza viruses, and over the last year has, I'm sure, been asked many questions about COVID-19. Tonight, Jane's going to share her experiences and some different perspectives on the various outbreaks in her sort of experience. So without further ado, Jane, I'll hand over the virtual microphone to you.
Thank you, Sarah. Right, so hopefully everybody can see that. I've changed the title slightly because when I started thinking about what Sarah had asked me to speak about, it was really how to use my own experiences in a couple of different pandemics and in the Ebola epidemic to talk about how policy is formed and some of the difficulties involved around that. So what this is not going to be about. This is not going to be a criticism or comparison of government responses. We're not going to be comparing between countries. It's not going to be a detailed review of the approaches taken during the current response, or indeed some of the previous ones. And I'm not going to make any predictions about where we're going, although that is a question that I guess asked absolutely all the time. So what is my background and how am I going to use that? So back in 2008, I joined the then Health Protection Agency, and I was employed on a Health Protection Agency funded project. I was the lead scientist. We were doing some very basic studies. At the time, we thought the next pandemic was going to be an influenza one. And the Department of Health were very interested in gathering as much information as possible about how does a virus survive on surfaces? How do we kill it? Quite literally, and with the ingredients that you find in your kitchen cupboard. I could tell you what those were, but it was interesting. And what they wanted us to do was to do this scientifically. So we had to find ways. I mean, if you told me as an RNA structural biologist that one day I would be getting the University Clinical School workshop to cut out tiny measured pieces of computer keyboard, glass windscreens, and indeed cuddly toys, and then putting carefully measured amounts of virus on them and working out how long that virus was going to survive, I would have probably laughed. But that data was important and it was very fundamental work. And it went on to inform the government response, actually, to what happened next, which was the following year, we had a swine flu pandemic. And I'll tell you a little bit more about that. In 2015, I, like many others in Cambridge, actually, Cambridge had a huge response to the Ebola outbreak in Sierra Leone. The Public Health England, as it was by then, put out a request asking for scientists to respond and go out. And we all trained. I was chosen as a team leader and went out and led a laboratory for about nearly 2 months out there. And that was an interesting experience from inside something that could have become a pandemic. And then latterly, of course, I'm now senior tutor at one of the colleges, and well, Lucy Cavendish College, and having to develop local policies in response to government policies in a timely and as clearly communicated as possible fashion. So a very different aspect of thinking about these things. So this poster, 2009, in fact, this poster, so as I've said, the work that we were asked to do by the Department of Health, funded by the Health Protection Agency, was looking at how long did virus survive on surfaces. That work was critical. There was a lot of anecdotal work, and you might be familiar with this in the current pandemic, but there was lots of work out there that talked about swabbing clinical settings, swabbing around patients, swabbing in homes of people that were infected with the virus. But that's very uncontrolled. You were just going there with literally with a swab, swabbing a surface and then counting what you found. And we wanted to do it in a much more measured fashion. And the data that we produced showed, not earth-shatteringly, that if you put a virus on a absorbent surface, unsurprisingly, it doesn't last as long as it does on a glass or pottery or metal surface. It dies much more quickly. That information actually was useful in multiple different ways, but it became the data behind this series of posters. And if you look around you now, you will see the cartoon version of this poster that has survived 12 years on that data. And it just said, if you catch, you're going to cough or sneeze, do it into a tissue, throw it in the bin, and the virus is dead. A very simple message that drove thinking around virus survival on surfaces and led to a lot more work. We also looked, as I've already said, at disinfectants, because the Department of Health said, well, if we have a pandemic, and we'll talk about timelines as we go through this, if we have a pandemic and people are shut up in their homes, does this sound familiar? They're going to need ways to clean the environment around them. What can they use? And honestly, I was using Jif Lemon, Fairy Liquid. I can't remember now, but also it literally was what you could find in a kitchen cupboard or under the kitchen sink. And that again has gone on to inform the advice behind things like wash your hands with soap and water, because actually it works to kill and disrupt the surface of an enveloped virus. So very basic research done very thoroughly lasts. Unfortunately, it takes time as well. We were lucky because we were ahead of the game. So the virus that we were using in those experiments is a very well-known lab strain called PR8. And PR8 happens to have the genotype H1N1. That's its, basically its outer proteins. And that was the same H1N1 as the incoming swine flu had. So we could say, hands on hearts, that this probably was as applicable to the incoming pandemic virus. And so we were able to quite quickly publish that work and get the message out there to the government, which was all very useful. And it led, unsurprisingly, to more work. So we got money. Well, actually, no, part of the original study had been to look at human-to-human transmission. And again, a lot of the evidence was anecdotal. It was things like infection of people in a plane. So there was a flu outbreak that happened as a result of somebody infected with flu sitting on an aeroplane and infecting people in a sort of array of seats around them. And that was known to be an example of influenza transmission. All seems, remarkable now, because you've lived through a pandemic, you know how these viruses transmit, but actually there wasn't total evidence on this. And so we worked with John Oxford, who had a company called Retroscreen, and Retroscreen did challenge experiments for vaccine development. And we did experiments where we had an infected individual, they were infected with a vaccine strain of the virus, and then you sat them in a room with 5 happy volunteers who are very well paid, and they played cards, and they did, shared games. They had things like I think it was Game Boys in those days, can't remember now. But they shared all this sort of stuff. They had tea and dinner and whatever together. And you look to see how quickly the virus transmitted in close conditions. And believe it or not, it was useful information. We also swabbed the environment around the people in the room and got information about how long did the virus survive when they were infected, and it spilt onto the surfaces around them. Again, all information that has fed into what we now know about respiratory viruses. Usefully for us, one of the co-authors on the original grant was Jonathan Van Tam, and so he had a direct link into the government, and we were able to get all that data rather rapidly disseminated. This is an example of, so that was rapid dissemination of information from scientific study, immediately informing government policy, immediately feeding into them, and somewhat fortuitously, as I've already explained. But the National Institute for Health Research brought out some extra funding specifically for swine flu. And £250,000, we wrote this grant application. So the virus peaked again, sort of early spring, summer, I think, if I remember rightly now, and then had a peak again in the autumn. And we only managed to catch the sort of tail because of the length of time it takes to write a grant, to get the team together, to design these experiments. And these were actually required a lot of ethical approval. This was going into the rooms of patients and community infected people. So they were identified either on hospital wards or in GP clinics, and then doing the same thing. And we were trying to be methodical about it. So we designed ways of only swabbing very tiny, small areas that were exactly identical, and then culturing the virus, which was not straightforward with swine flu, and also doing PCR to look for RNA genome. That came out in 2010 in the NIHR's own journal, which is the, oh dear, I can't remember what it's called now, the HTA. But it actually didn't get published for a number of years after that because, by the time we were doing it, we were only able to recruit a tiny, 40, 50 40 or 50 patients into each cohort. And it wasn't, statistically, it was hard to make that fly. So it's a question of when we're looking at the science and everything now, the same thing will be happening. The success of the lockdowns and the vaccines actually will limit the amount of research that gets done. And I can think of at least one study I know of in Cambridge that's, scraping around to find subjects for that study because there aren't very many. That's a good thing, obviously, but it limits what you can get out of a pandemic or an epidemic. But you do learn things going forward. Swine flu showed us very, quickly just how fast these things happen. So literally cases in Mexico, 1 week, 2 weeks later, cases in North America reported the week after that, a PCR test out about a week after that, and declared, I think this was sort of December-y time, the usual respiratory virus thing, and within a short space of time declared a pandemic by the WHO. There was criticism of our government. I'm not going to be critical of them, but there was criticism that we overreacted. This virus only killed, and this will seem very strange now in the aftermath or during COVID, but it killed 472 people in the UK. That's not very many people. And we deployed masses of vaccine. We deployed a lot of antivirals. We bought absolutely masses. Millions of pounds worth. And there's a great deal of criticism. They jumped in too soon. Well, I think as I go through, you can be the judges of that, what is too soon. There's a theory that the government was, what do you call it, ambiguity averse. So basically they were not keen on the idea that there might not be a serious virus, that you should deal with the worst case scenario. And so that's what they did. And I wonder now, and we can discuss whether that has had a knock-on effect in the case of COVID. So this, it skipped it does this occasionally, sorry, so it skipped a couple of slides, but that doesn't matter. This is one of my team in Sierra Leone. So in 2015, I was part of the Ebola response. Now this outbreak actually happened, you know, a year plus before it was started, sorry, was initiated a year plus before that. So we think the initial case in this particular outbreak was in Guinea, in the country Guinea, and it's thought to be a child who was playing in a tree in which there were bats that were infected with this particular strain of Ebola. And he got sick, was infected with the virus and took it back to his family. And from there, it gradually built up. Within the space of a month, it had spread fairly quickly. In January, the cases started being reported. The WHO actually reported the cases. By February, certain well-known medical charities were responding and saying, this is something we need to be dealing with. And it started to spread. It spread into the neighboring countries, Liberia and Sierra Leone. And with that spread, things accelerated. And it was March before the WHO actually pronounced that this was a pandemic. No, actually it wasn't March when they pronounced it. In March, they said, this is a serious incident. We need to be doing more. It was August before it was declared a pandemic. And that was because of the localization of it. This is Ebola. It's had spread in these three countries, but it wasn't until cases started to be exported by, I think, at least a couple of businessmen, but also by healthcare workers going back to countries to be treated or going back and then developing Ebola, that it really flagged up. And in fact, the international response is said, it's been criticized. It's been criticized as being slow, and the blame is usually firmly put back with the WHO, which may or may not be fair, because they waited on that moment. And when it happened, and I think when we also had 2 healthcare workers that were infected come back, then we responded very fast. There's, so this country is incredibly beautiful, and it had a raw deal. It was a long time before, months and months before we responded as an international community. And there were more than 28,000 people infected, 40% of whom died. And they died horrible deaths, terrible deaths. So the lessons learned from Ebola needed to be thought about. These are the countries that it spread to. So it got to Italy, it got to the other African countries where there were more cases. And that was the point when it started doing that, that was the point at which the WHO said, oh, pandemic, we need to respond. But I think some of the responses from other countries was around their own healthcare workers bringing it back. And in fact, in some of the American cases, it was healthcare workers in the USA that then developed disease, treating people who'd returned it infected with Ebola. So after all these sort of incidents, massive outbreaks, pandemics, there's always a review. You'll hear the opposition parties jumping around saying, we need to have a review. The review is going to happen anyway. It's always going to happen because you have to do a lessons learned. But at the time, the International Development Committee, which is put together by the House of Commons, and they looked into the response by the Department for International Development, DFID, who were running the response for the UK. And there's 3 recommendations or 3 comments at the end of that report, which is publicly available. And basically the first one was very positive. It said amazing response. It was, if you were part of that response, the slide I can't show you was me outside the mock-up laboratory in Porton Down, where complete mock-up of the actual setup you're going to work in Sierra Leone, so that when you landed there, and I've got a lovely picture of the actual Ebola treatment center with that lab in it, but you were familiar with your surroundings. So it was very military. You knew what you're going into, you knew where everything was going to be, you'd practiced evacuation routines, all the rest of it. So an amazing response. But they were very critical of the lack of time, the weaknesses this showed across the international system. This is a strong statement, especially unfortunate considering the remarkable effectiveness of the response after it had been scaled up. Unfortunate because there were 11,000 plus deaths that, many of whom need not have happened. The mobilization came far too late, by which point the response was already playing catch up. And that is a problem. And it's this balance between responding too fast, if you can respond too fast, that's for discussion, or responding too late and waiting to see if this is going to spread outside the countries that you should be helping in the first place. And they go on to say, that, and this was in the report, so this is 2016, this is only 5 years ago. And I question whether we really took this on board. So the responsibility rests with the entire international community, that you need that talking between the communities, including the UK. Such an outbreak can never be allowed to occur again. Well, sadly, we've had another Ebola outbreak since then in the Congo, or to develop so catastrophically due to international inaction. It's very damning, quite damning words. So what happened after that? Well, we didn't sit around doing nothing. Before SARS coronavirus 2 came along, we did have, we got a slide here. So we did have, I think this was 2018, maybe not, maybe it was the year before. I can't remember now, actually. It's gone from my brain, but Exercise Cygnus involved nearly 1,000 workers in different parts of a pandemic response in the UK, mocking up what would happen if we had and it was believed to be an avian flu outbreak. Avian flu does infect humans. When it does so with huge lethality. So there's H7N9, H5N1. These viruses, kill, I think one of them 30-something%, the other more. I can't remember the exact percentages, but they have a massive lethality. Luckily for us, at the moment, they do not spread person to person. But in the back of every virologist's mind is what happens if they mutate, and you're all familiar now with the idea that viruses, RNA viruses in particular, mutate and form new variants. So this is what drives the fear of avian influenza. And so they did a reasonably successful pandemic response practice, a major one, and then came up with these learning outcomes. And what is important to know is that we knew these things. I think the first one probably is absolutely fine. And we know that the second one was followed and did come into place because literally, a couple of days after a lockdown being announced in March 2020, we had new legislation, didn't we? And we were under new laws brought in specifically to respond to a pandemic. So in this instance, that reacting or trying to think ahead to what might happen in the event of a pandemic has informed policy and has worked. There's an interesting one, public reactions in response to a reasonable worst case. Again, that little bit about ambiguity, averseness, needs to be better understood. So understanding human behavior. That in the context of Ebola was very important. It was the major error we made, probably the only error we made when we went in. And that was not taking cultural differences into account and going in and thinking you could just set up Ebola treatment centers and people would roll up to them, and that didn't happen. So this is a very important thing and is informed by the Ebola epidemic, but also by thinking around what might happen in the event of a pandemic. And if you think about how much time now is spent on trying to be clear. Very, very difficult. And, you know, we can discuss whether you think they've been clear or not. But trying to be clear and trying to, people are not stupid. They do need to have things explained, and they will engage and understand. They really will. And the last one, I think we failed utterly at the beginning of this particular pandemic. Require capability and capacity to surge services to meet demand. We have that now, but we are 12 months on. So what have we learnt or been reminded of with SARS coronavirus 2? And the first thing is that things happen fast. It's almost identical to the timeline with Ebola, actually. It's not dissimilar to the timeline with swine flu. These sorts of pandemics with these viruses that are spread more easily, Ebola is not spread so easily. It requires quite close contact. But the respiratory viruses, you all know now just how far apart you have to be not to be infected, and the mitigations that you need to have in place. But again, with SARS coronavirus 2, it was sort of around December time, we think, in China when the first cases were announced. Again, it was a little bit slow, that there wasn't immediate lockdown of those areas. Flights still continued to international communities. Probably the virus, from the way it then sprung up all over the world, it wasn't sort of hopping country to country. It was probably spread by infection going out from the center at the time. And there was, you know, countries were not always quick to stop travel, to keep that on hold. So again, the virus was out of control by the time here we'd realized that the pandemic was announced much more quickly. So March, the WHO announced there was a pandemic happening. We announced the lockdown just not long after that, a couple of weeks after that, March the 25th, maybe, springs to mind. And then, you know, you can follow the outbreak around the world after that and how quickly it spread to other countries. And you know how quickly the numbers ramp up. So if it's already on the ground and already there in large numbers, you can get to very, very large numbers, very serious things very quickly. So science cannot always keep up. So one of the banes of my life during the coronavirus pandemic has been preprints. They are both a wonderful thing. You're probably all familiar with them. The newspapers adore them because it's the quickest way to get new information. So every reputable journal has now got versions where you can see papers before they've been peer reviewed, before they've got into the real journal, as it were. There are even sites that just, you will know of them by now, but there are sites that just specialize in having these sort of preprint papers up. So papers that are going to be sent to other journals for peer review can get published on these preprint sites. Now, if you're working in the field, these are marvelous sources of data and ideas and potential collaborators, because you can see what's out there, you can see the wealth of research that's going on. If you are the scientist that has to sit on national radio and answer the questions about, have you seen the latest report? And you have to say, it's actually not a report yet, it's just a preprint, it's not been peer reviewed, etc. It can be quite frustrating. And also governments will respond to them. So despite having advisory groups, which you're all familiar with, SAGE and other such committees, despite having the advisory groups, still that they're being fed this information by their own researchers going, look at this, what do we think, should we be responding to this? And they're having to turn to their scientists and say, what do you think about this? To actually then get the data is often months and weeks down the line, and you can make wrong decisions can be made. I'm not for a minute saying that they are, but there's the potential there. And science can't keep up. To get the data, particularly as populations start being vaccinated, and so they're no longer vulnerable to the virus, it gets more difficult. So you start looking around to different countries and trying to do comparisons and meta-analyses. So science is amazing, and there's some wonderful things happening. I mean, the vaccines are, you know, they're the absolute gold standard for science being done on a massive scale, scaled up, lot of work and effort and risk being put into that. Companies taking risks to roll out, you know, multiple different vaccines for trial that are not all going to work. Governments pumping money into it that are not all going to work. But in this instance, proving their value because we're dealing with a virus that does have a higher fatality rate. Nothing like Ebola, nothing like some of the strains of flu in the past, but still serious enough to cause massive impact, as you were all aware, on health services around the world and on economies. And then I am going to come back to this because I think we're just having this hammered home again. And if we have to take, you know, another lesson learned from this, it's about communication is key. I know this on a local level because we all spend a lot of time thinking about how we communicate the latest bit of information from the government about how many people can meet outdoors, how many people can come into your house, how do we manage this? Should we or should we not be wearing face coverings? What's the data? What's the current policy? Yeah, I think our university's done a marvelous job of communicating very, very clearly. But that was because they made a decision to put a communications team in place to do exactly that. The government, it's been difficult, hasn't it? Because we started out with a single lockdown. Then we rolled over last summer into a phase of sort of localized lockdowns. And then we ended up in the autumn with the tier system, which made a lot of economic sense, but from a communications point of view, it was diabolical because people were going, well, which tier am I in now? And what happens in my tier? And what happens in that tier? And if I travel to the other side of the country, or Wales or Scotland or Ireland, what do I have to do? And much harder to communicate. So actually one of the lessons back in that, what was it called? I've forgotten now, the Cygnus practice, was that actually it would be important for the governments to work together and try and drive single policies, or at least as closely aligned as possible. And you know, from watching the news on a week-by-week basis, that has not happened. There's always variance. So if you're going north of the border, you have to think to yourself, well, do I wear a face covering outside? Or can I do this? Can I not do that? Creates confusion and it creates a sort of apathy as well. So communication is very, very important. I think, it's not going to play the game. Sorry about that. There was a last slide. Oh, there we go. I do want to say there is, you know, it's not all darkness, and we are in a better place, and the vaccines are, they are proving their worth. They really will. They are. I was slightly skeptical at the beginning, but they are the way out of here. But what matters now is the policy around getting those vaccines around the world, because there's no point in us having a very low incidence rate, you know, days of 0 deaths from coronavirus, if all around us things are still not in a good way. So we do need to work together as an international community as well. So I think that's the end. It is. Oh, there you go. That's the, I just had to put that in because it's still there. I shall stop screen sharing. So I hope what I was trying to do was just give you a little bit of an insight from a scientist's point of view into what's difficult sometimes about helping with policy, about following policy, and the frustrations of lessons not always being learned. And I guess there's a level of pragmatism sometimes in the decision, well, always in the decisions being made.
Thank you, Jane. That was a really interesting talk, really interesting to hear about all your different experiences with the various outbreaks. I'd like to open up the floor for discussion now. So feel free, everybody, to post questions in the chat or unmute yourself and ask, but I'm gonna get the ball rolling with one of my own questions. You mentioned exercise sickness, was it?
Yeah.
I thought that was really interesting. And I don't know if you mentioned whether it's an international or a UK-based exercise. And I was wondering, like, what is the role for international collaboration in terms of pandemic preparedness?
Well, that's a very good question, Sarah. It was a UK exercise in that instance. To my knowledge, but I mean, others may know better than me, but I don't know of anything being done or tried. It would be a fascinating thing to try and do, maybe in a simulated or virtual way, to try post this something on an international scale, because after Ebola, I thought that we were now prepared to be much more on the ball about keeping surveillance up to, really doing surveillance at all times, being up to speed on, and then communicating very quickly. And countries do. I mean, China got the sequence of that virus out very fast. You think back to swine flu, the CDC had sequenced that virus even back in 2009, very incredibly rapidly, got the sequence out within, a couple of weeks. But yeah, it would save an awful lot of lives if we had better collaboration between countries and better sharing of information. I've forgotten the second part of your question, actually, sorry.
I was just wondering, do you think that there is a way forward in terms of international collaboration, maybe like a post-COVID world,
Yeah, I think there is hope there. I mean, there are instances where that works very well. So the prime example of that, the easiest one to think about, is flu surveillance. So flu surveillance is an international operation. So all around the world, there is, sharing of sequences, following of viruses, instant, the instant a new avian virus is seen, that we know about it. It's out there, everyone knows, everyone's aware. It works incredibly well. But actually, for more unusual pathogens and for actually having those, there isn't, as far as I'm aware, an easy means of having those immediate conversations about, are we all going to work together on this? And you saw the public fights over things like vaccines. It's pretty ugly, not very satisfactory to see.
Yeah, thank you. Orla, I think, has posted a question in the chat. Perhaps you'd like to ask that. It's quite related.
Yeah, I can do. Yeah, it's kind of similar, I guess. I was just wondering why you think that lessons haven't been learned from previous pandemics. Why is that messaging not getting through, I suppose, to governments, both the UK government internationally, and how can we improve this going forward?
It's a good question. I mean, really, the WHO should be the means for sharing that information and for ensuring that governments, and they work hard to do that, but governments have their own agendas, they have their own fears. And, in the face of this pandemic, you could visibly see the government going, oh my goodness, this is going to affect the economy. This is going to affect, quite apart from all the other terrible effects we now know that the pandemic is having. It was the thought of everything grinding to a halt that was staring them in the face. I think that happens around the world. There's some dreadful instances of countries just where they didn't want to believe in the virus, that this was happening. And, you're all familiar with South America and parts of Asia where that was the case. So there's some just government responses that were never going to be collaborative. I guess one can hope that the WHO, organizations like the UN might be able to work together to come up with some good, clear policies, good channels of communication. How do we stop this from happening? Because the effect globally on economy will be, terrible, and it will be worse for some countries than others. So the straight answer, Orla, is I don't know. Sometimes things are done very well. The WHO has done a global assessment of some mycobacterial resistance to antibiotics. And that is a global understanding, a global look at where everything has been done very differently. And that's another issue. The responses are different, you know, the way you test for the virus, the way you look for the virus, the way you treat the virus is different. In that instance, they've actually made a massive effort to say, right, we need to control TB and we don't want drug resistance globally. So let's get together and work on this. And that's, you know, a major effort across the world. So it can be done, but you know, that's one organism. And what we're dealing with here is the fear that something else will pop out of the woodwork. All of these viruses have links to zoonoses, or at least to animal transmission. Swine flu from pigs, obviously, Ebola from bats, and coronavirus probably from bats via possibly something else. But you know, they're out there, and particularly the RNA viruses adapt very quickly. So I don't know is the straight answer to your question, but there is hope, and there are precedents for very good things being done, flu, TB, to make global surveillance, global collaboration much more likely to happen.
I think Heather Turner has a question. Would you like to ask your question, Heather?
Yeah, sure. So I was just thinking about before COVID, everyone thought that the UK was particularly well prepared for a pandemic. And I was just thinking, in the future, what would you suggest as sort of metrics for countries to evaluate their preparedness for a pandemic, and perhaps also considering more international metrics?
I think when we do our look back, we need to say what were the things that drove things? What were the things we didn't do well that meant that the pandemic, the virus, was out of control in this country too quickly before we thought we had surge capacity. We thought we knew how to build, you know, the Nightingale hospitals, the big testing centers, that those, you know, when they happened, those things existed, and the testing now is phenomenal, but it's, you know, it's a long way down the line. So what should happen is that you can get there, but you should be able to control the virus enough in the very beginning. And probably I will be unsurprised if that doesn't turn out to be managing travel much better. If you think about swine flu got to Scotland in the space of a matter of weeks from Mexico. And that was because there were direct flights from Mexico to Glasgow. That's how it got into the UK. Ebola came home with the medics returning. So we know that travel spreads these viruses much more quickly. I think that would be a major point, Heather. I think it will be critical to see what stops us from being able to, despite being, as we think, prepared, because you cannot stockpile enough PPE to be prepared for a pandemic every year on year. It will go out of date, we'll keep throwing it away. So those, possibly there can be improvement around that side of things, but it's really controlling it at the very beginning, slowing that initial spread down, doing what they tried to do, but the genie was out of the bottle, frankly. They tried chasing cases around the country. So it's when they're making policy post this, they need to be thinking about how do we stop it? You think of the countries where it's barely tickled them, you know, New Zealand, Australia, other countries in Asia, that they were hard-nosed about it. They just shut their borders. And, you know, whatever you think about that, it was effective. And that would be the single thing probably down the line. You then have to model what happens if you don't do that, if it's already got here, if it already spreads much more fast, quickly. And there are variants out there now that are, you know, showing signs of being quicker spreaders, unfortunately. I think other things we were prepared for. I mean, look at the vaccine ramp up. Sorry to say that again, but you know, faith in those industries and allowing them to work that fast was effective. The ability to, the logistics, we're good at that. You know, we can build hospitals and places quickly. We did not have enough staff. I mean, I don't know if any of you worked in the Nightingale Hospital or volunteered, but I know people that did. And they went down there and there were no nurses. They were down there to run tests and laboratory side of things, and there were no nurses, you know. So these beautiful, great echoing halls with beds in, and, you know, what do you call them? Can't think of the word. Oxygen, but no nurses to deliver it or to look after the patients. It was ridiculous. So there's much work to be done and thought about and thought through. And it's just a case now of learning those lessons, really. And I think going back to Ola, it's thinking about how to work with international colleagues better and advise them better and more quickly and get the vaccine out to them too.
Thank you. We have another question in the chat from Shan, but before we move on to that, I just wanted to pick up on your point about travel and ask, you know, in New Zealand, where I'm from, you know, they shut the borders and stuff, but it seems like for them, they're kind of just delaying the inevitable. And now, you know, they can't open them because otherwise it will be terrible. There's no vaccines. And I was, you know, what are your thoughts on that in terms of policy response?
Yeah, well, then again, you have to say that that's the lesson there is that it's not sufficient just to shut your borders, is it? You do need, and that's where the global community has to come in, isn't it? It's that understanding that where countries have not been able to develop their own vaccines, you need to be able to get the vaccine to them, and you need to. If we don't, we're going to have pockets of coronavirus for, you know, ongoing now. I know we're all kind of, well, it'll just become like influenza and we can just get vaccinated once a year and that'll be fine. Everybody who's vulnerable will get vaccinated. We're already doing the experiments that look at mixing influenza vaccine with SARS coronavirus 2 vaccine. So that's, you know, that's on the cards, but it's not 100% protective. You know this, you've heard this. So people will still get infected. We need to, even if just looking after ourselves, we need to help the international community more broadly. So yes, it's not sufficient. You need the both. You need to stop it, slow it, and then protect the population. And whatever that virus is, that's what you need to do. Sorry. Who else? Is there anyone else?
Shan, I think, had a question.
Yeah, thanks. Yeah, my question is, you mentioned that there's always a review. And is it a government-initiated review or academic-initiated review? And what is the follow-up of the review? Would the current or successive administration learn lessons from it?
We'd hope. The government will always review. They don't, I mean, it's not an independent review necessarily. It's a committee that's picked by the government to do a review, but there will be other reviews, I'm sure. And yes, there'll be 1,000,001 scientific reviews of what goes on. And I'm sure many people will compare you know, the different responses. It's hard to do that. The different down the line, the different vaccine programs, policies like Sarah mentioned of just, you know, shutting the borders down, all very well. But if you're then stuck there, being unable to let people in or out because you've got an entirely vulnerable population with, I know we're not meant to utter the words herd immunity, but there is no herd immunity either because they've not had it. Then you need to think around that as well. So what should happen, Sian, is that we take the findings of these reports and we create new and better. If you Google it, the government always has a pandemic preparedness document. If you look, interestingly, it had not been updated until last year for some time. And in fact, I couldn't find an update of it post the Cygnus experiment. So it's, yeah, that's what should happen. I would imagine that all governments do similar reviews, and I'm sure the WHO will do its own review of responses. It always reviews itself, for instance, after these sorts of instances. So you need to do that in order to just say, well, what could we do better? And what did we do well? What worked? And I think we're reasonably clear on that now down the line. But there were some, there were some political decisions made early on that did slow down things like testing, that did slow down some of the surveillance. Is there anything else? Sorry, I can't. Answered everybody's questions.
Yeah, if anybody else has any questions, feel free to unmute and ask now.
That's good.
I have a final question from me after just while people are thinking. I was just wondering, going back to that communication point, and I know you said you weren't going to criticize the government, and I not trying to force you to do that, but I was wondering how the sort of politicization of quite a few of the issues, for example, in the US, masks being such a flashpoint, how that affects the communication. Like, as a scientist, is that frustrating?
I think yes, it can be very frustrating. However, as a senior tutor, I'm always aware that there's a multitude of opinions about these things, and I understand something about how people are always suspicious of the government. I'm sure you've had talks in your centre about sort of fake news. People are suspicious of things they're told, is this real? And they believe all sorts of things on social media. So there's a massive influence there. I think it can be very difficult. And the only way to do it is to remember that people are not stupid, to remember that the best way to tell them about science and the best way is to actually really explain it. And a number of times people have said to me, it was really helpful to see, that diagram where you showed if this was the distance between people, they got this much virus. If this was the distance, they got that much virus. People like graphics. They like clear explanations of why they might become infected. And a lot of it's not rocket science, but there's a suspicion around being told, is the government just telling us these things so that we think we're doing something? So actually you have to explain it. That's why, going back to the swine flu, catch it, bin it, kill it, it was important to actually be able to say, but we did the science and we showed that if an influenza virus particle lands on a tissue, it's dead within less than 5 minutes, basically. So we knew that, we could show it. And people respond to that. They do respond to being told very clearly that there is a reason for this.
Thank you, Jane. Last opportunity to ask any questions. Feel free to unmute.
Yeah, can I ask, I feel like now social distancing is sort of being heralded as this magical tool that no one can ever get infected, like including in the government's own messaging. They seem, if members of whatever committee are in the same room 2 meters apart for 5 hours, it's impossible. They could have caught COVID from each other. Do you think that's still valid as a communication tool in general? Or now that everyone's kind of rushing back to the pubs, it seems a bit of a concern that people think if they're 2 meters away, it's impossible to be infected.
Yeah.
Or unlikely.
No, I agree, Alice. I think there's a danger in oversimplifying messages, that it's a good point, because if you just say, well, 2 meters, that's absolutely fine. There's 2 meters and there's 2 meters. 2 meters and you spend an hour talking to somebody and they start coughing, it's not going to help you. 2 meters in a room with poor ventilation, it's not going to help you. I mean, we watched the foreign, how should I put this? diplomats arrive a week or so ago, and you know how quickly they passed infection around one another. That was just because they were traveling, you know, close together in an aeroplane, basically, and one infected individual to start with. So we do need to, we mustn't think that people, you know, we shouldn't oversimplify communication. I think we should say, yeah, you need 2 meter distance, and actually 2 meter distance if you're outdoors is more than enough. You know, the wind and everything else, the ventilation around you, pretty safe. But that 2 meter distance in a corridor that's not properly ventilated and you're not both wearing face coverings is not particularly safe. Those virus particles can pass. They will reach that distance if somebody happens to cough or they're a heavier breather. We've shown that virus, depending on how you breathe, how you speak, virus particles are spread to different distances. So no, it's a fair point. I think you can oversimplify communication and make people feel, you know, are too relaxed. Pubs, yeah, I'm not quite ready to go indoors yet, despite being, you know, fully vaccinated. I will be sitting in the pub garden and hoping the weather stays fairly good. I think I've silenced them all now, Sarah.
All right, well, in that case, we'll wrap up there. So thank you so much, Jane, for sharing your insights tonight. It was really interesting to hear about all the different pandemics, and I definitely learned a lot from your experience. So thank you very much.
It was a pleasure. Thanks for inviting me. It's nice to speak to people.
Thank you. And thanks to our audience. And I hope to see you in a lecture soon.